Chronic interstitial nephritis. Chronic interstitial nephritis is characterized by renal dysfunction with fibrosis and infiltration of the renal parenchyma by lymphocytes, plasma cells, and macrophages in association with tubular damage. Pathophysiology. This disease may follow on from a IN that does not resolve or may be associated with ingestion of various toxins and drugs or with metabolic and chronic inflammatory diseases. In many patients, CIN presents at a late stage and no underlying cause can be identified. Genetic causes may underlie many of these cases. Toxins that have been associated with CIN include those contained within the plant Aristolochia clematitis, birthwood. These are probably responsible for the severe nephrotoxicity that can be associated with treatment with herbal medicines in Asia and for Balkan nephropathy, which affects isolated rural communities in Bosnia, Bulgaria, Croatia, Romania, and Serbia, possibly through contaminated flow. The nephropathy is commonly linked with tumors of the collecting system and is probably due to the mutagenic effects of the plant toxin on the urothelial epithelium. Ingestion of mushrooms within the Cortinarius genus can cause a devastating and irreversible renal tubular toxicity. It is encountered occasionally in Scandinavia and Scotland. Now the clinical features. Most patients with CIN present in adult life with CKD, hypertension, and small kidneys. Urinalysis abnormalities are non-specific. A minority present with salt-losing nephropathy characterized by hypotension, polyuria, and features of sodium and water depletion. People with CIN have an impairment of urine concentrating ability and sodium conservation, which puts them at risk of AKI due to salt and water depletion during an acute illness. Renal tubular acidosis may complicate CIN but is seen most often in myeloma, sarcoidosis, cystinosis, amyloidosis, and Sjogren's syndrome. Management is supportive in nature with correction of acidosis and hyperkalemia, replacement of fluid and electrolytes as required, and renal replacement therapy if irreversible renal damage has occurred. Now, causes of chronic interstitial nephritis. Acute interstitial nephritis. Any of the causes of acute interstitial nephritis is persistent due to glomerulonephritis. Varying degrees of interstitial inflammation occur in association with most types of inflammatory glomerulonephritis. Immune or inflammatory cause. Sarcoidosis, Sjogren's syndrome, chronic transplant rejection, systemic, lupus erythematosus, primary autoimmune. Due to toxic cause. Aristolochia in herbal medicines, lead, Balkan nephropathy, mushrooms. Due to drug cause. All drugs causing acute interstitial nephritis, tenofovir, lithium toxicity, analgesic nephropathy, cyclosporin, tacrolimus. Infection cause. Consequence of severe pyelonephritis. Congenital or developmental cause. Vesicoureteric reflux associated but causation not clear. Renal dysplasias often associated with reflux. Inherited, now well recognized but mechanisms unclear. Other Wilson's disease, sickle cell nephropathy, medullary sponge kidney, nephrocalcinosis, metabolic and systemic diseases such as calcium phosphate crystallization after excessive phosphate administration, example phosphate enemas in patients with chronic kidney disease, hypokalemia, hyperoxaluria. Now, papillary necrosis. The renal papilla lie within a hypertonic environment in the renal medulla. At the end of the vasa recta, they are susceptible to ischemic damage because of these and can undergo necrosis when their vascular supply is impaired as a result of diabetes mellitus, sickle cell disease, or long-term ingestion of NSAIDs. The condition may occasionally occur in other diseases. There is an association with pyelonephritis, but it is difficult to determine whether this is a cause of papillary necrosis or a complication. The clinical presentation is variable. Some patients are asymptomatic and clinically silent, whereas others present with renal colic and renal impairment as necrosed papilla slough off and cause ureteric obstruction. Urinalysis may be normal, but more frequently hematuria and sterile pyuria are present. Significant proteinuria is unusual unless there is renal failure. The imaging method of choice to make the diagnosis is CTU or intravenous pyelography. Management is based on relieving obstruction where present and withdrawal of the offending drug.